G'day, I'd like to let you know that AussieMedEd is sponsored by Tego. For most doctors, indemnity insurance is one of their biggest costs of practice. While many doctors are still with the same insurer they joined in medical school, many have made the switch to Tego and benefited from it. The team at Tego have told me that those new to private practice could qualify for 4 years of discounted premiums. To find out more about Tego, visit tego.com.au. That's tego.com.au. G'day and welcome to the AussieMedEd, the Australian Medical Education Podcast, where we get to interview specialists in a variety of medical areas, asking their opinion on their certain conditions and obtaining their insight into how they diagnose and treat that condition. In these COVID times, it's a way of replacing the relaxed discussion around the hospital by allowing the listener to put forward questions to be answered and addressed on their behalf. I hope you enjoy the whole program. Welcome once again to AussieMedEd. In this episode, we're going to present an orthopaedic topic, the area of shoulder surgery, which is my area of expertise. As such, in this episode, I've decided to discuss the issue of shoulder pain, both the assessment of patients with the conditions, the various causes of it, how to make the diagnosis and the investigations required, and the treatment of the most common causes of shoulder pain, that being the rotator cuff spectrum, including impingement, bursitis, tendinopathy, and rotator cuff tears. I'm Gavin, an orthopaedic surgeon based in Adelaide in South Australia, and I'm the host of this podcast. I'd like to begin this podcast by acknowledging the traditional custodians of the land on which this podcast has been produced, and pay my respects to the elders both past and present. Okay, a little bit about myself. I'm an orthopaedic surgeon, having graduated from the University of Adelaide. I worked in the United Kingdom for a period of time before heading back to Australia. I'm a fellow of the Royal Australasian College of Surgeons and also the Royal College of Surgeons of Edinburgh, and also a fellow of the Australian Orthopaedic Association. I hold the senior lecturer position at the University of Adelaide and am involved in medical student teaching, particularly the 4th years and 6th years at the university. It's my passion for orthopaedics, as well as teaching, that's made me introduce this idea of doing this podcast, and as such I'll introduce a topic of my choice, that being shoulder pain, which is a very common question that's put to me as a senior lecturer. So shoulder pain is really the most common thing that I would see in my orthopaedic practice. It's really a very common question put to me by general practitioners and medical students on how you assess it and how you treat the various causes of it. Really, I start off by saying that the first most important part of it is to actually exclude other causes of shoulder pain as the cause. In other words, depending on where the pain is actually experienced, depends on whether it's actually shoulder pain or it's arising from some other area. For example, I put down the fact that pain felt down the medial border of the scapula or in the posterior triangle of the neck is more likely to be related to the cervical spine, as well as pain on the front of the chest wall being more likely to be related to the ribs or from a muscular cause. Shoulder pain is generally felt on the front of the shoulder or laterally. Pain on the front of the shoulder seems to arise from the glenohumeral joint, while pain laterally is more in the subacromial area and the bursal region. One must never forget that cardiac causes can also cause shoulder pain, particularly left-sided shoulder pain as well. So when we start looking at a shoulder cause, we look at the actual side of pain, and if the pain is actually either medial border of the scapula or lower in the chest wall or in the axilla, I start thinking that it might not be related to the shoulder in itself. When we come to the causes of shoulder pain, it's really important to know the various diagnoses. And I actually like to divide this up into a simplified pattern. Really, unless you know the various diagnoses that occur in a condition, you can't actually make a diagnosis. An example being, unless you know what you're looking for, when you go to assess a patient, you can't form a formal diagnosis because you don't know what the various options of diagnoses are. The way I think about it is how a patient might present. They might either come through a clinic and see them in outpatients, or they might come through emergency as a traumatic presentation. And thus we divide the traumatic presentations into things that have been caused by a trauma, such as a fracture or dislocation. And sometimes infection can present this way. They recall a small trauma, or they may come through casually with severe pain. But really, I divide the traumatic presentations into fractures, dislocations, and infections. Included in this group could be acute ruptures of tendons as well. While the elective conditions are usually ones that present in a clinic, and they relate to the condition itself. In the shoulder, it relates to either rotator cuff spectrum, that being bursitis, tendinopathy with secondary rotator cuff tears, or then secondary osteoarthritis, or it can relate to arthritis of the glenohumeral joint or another part of the joint in the shoulder, or also relate to frozen shoulders. So let's put this in a simplified fashion. If a patient presents in a traumatic fashion, i.e. they've had a fall or a major trauma or injury, then that's a traumatic presentation. And when we think of a traumatic presentation, we think, what can occur? Is it a fracture? Is it a dislocation, or is it an infection? So if someone falls on the football field, could it be a fracture or dislocation? Okay, what could be fractured? Obviously, the most obvious cause is a bone. What bones make up the shoulder? There's 3 bones, really. That being the 3 bones being the clavicle, the scapula, and the proximal humerus. If there's a dislocation, what can be dislocated? The obvious answer is a joint. The joints that actually make up the shoulder, there's 3 of them again, following the rule of 3s. There's a sternoclavicular joint, which is a fairly stable joint and doesn't often dislocate, but can occur on occasions. There's the AC joint, which is a very common cause of dislocations. Or there's the glenohumeral joint itself, which is the main proximal humerus dislocating out of the glenoid socket. Infection can involve either of the bones or the joints, and as such, a patient may present with a traumatic episode, recalling some major trauma, but really the infection has been brewing all along. In other words, once or twice a year you might see a primary infection. It's usually more commonly occurs in someone who's immunocompromised, or in a younger age group or the older age group, or if they've had a surgical procedure. The elective conditions really relate more to the main conditions that affect the joint itself. So we don't have a simplified pattern to try and think of the elective conditions, but really you have to know the actual individual joint. And when it comes to the shoulder, the main causes of elective presentations relate to the rotator cuff. The rotator cuff is a group of muscles that encircle the glenohumeral joint, which provide stability to the shoulder and also fine movements. They comprise the 4 muscles being the supraspinatus, the infraspinatus, subscapularis, and teres minor. All of them help control the shoulder joint in itself. The supraspinatus is a depressor of the humeral head to allow the deltoid to allow abduction of the shoulder. The subscapularis' main function is internal rotation of the shoulder, while the infraspinatus' main function is external rotation of the shoulder, along with teres minor, which also externally rotates with the arm in the abducted position. All these can present with pain. Rotator cuff conditions present really as one of 3 or 4 main ways. There's the primary bursitis, which occurs in the younger person when they've done a lot of overhead work, and they experience pain laterally in their arm, worse when abducting between 70 to 120 degrees of range of motion. As you get a bit older, the tendons themselves degenerate slightly, and as such, the same thing occurs, but the pain tends to linger on longer and doesn't settle quite so quickly, and can often be bothering the patient more at night. As the patient deteriorates in age, and hastened by other factors such as excessive overhead work or by smoking, which can degenerate the collagen fibers in the tendon, the person can go on to develop rotator cuff tears. And as with any joint, as the rotator cuffs tear, then the joint becomes a little bit more unstable, which predisposes it to develop secondary arthritis. So rotator cuff spectrum presents in that same 4 fashion: bursitis, tendinopathy, rotator cuff tears, and then secondary arthritis. Other conditions that can occur in the shoulder are osteoarthritis, and this usually presents with pain felt more anteriorly in the shoulder, affecting the glenohumeral joint. As the arthritis deteriorates, the range of motion slowly deteriorates as well. The patient might experience some crepitus or bony crepitus, such that when they externally rotate their arm, they feel or hear some noises in their shoulder. Now, these noises can also be felt in the subacromial space with rotator cuff tears, and this is known as a soft tissue crepitus, as opposed to the bony or hard crepitus you get with osteoarthritis. Osteoarthritis can also affect the other 2 joints in the body, the sternoclavicular joint, and that usually presents more common in ladies as they notice it because their neckline's usually lower and they're looking in that area while they put the necklace on, and they'll see a lump appear over the sternoclavicular area and often some discomfort or an ache. And then also laterally the AC joint, and this is more common particularly in gentlemen who played sport or they've done a lot of push-ups, such that as push-ups put a lot of force through the AC joint, that can cause the AC joint to degenerate, and this can lead to a lump appearing at the acromioclavicular joint or pain when they're abducting more above the 70-degree range. You're looking more at 150 to 180 degrees or end range of motion. It's also experienced on cross-arm abductions. In other words, when the arm is pushed across the chest, or known as also as a scarf test when assessing that particular movement. The third main conditions that occur in the shoulder is the frozen shoulder conditions, and this is an unusual condition. It's very common. No one really knows why it occurs. There's a lot of theories, and it's more associated with diabetes, as well as I have seen it in people who have had previous radiotherapy or ladies post breast cancer treatment. It needs to be differentiated from osteoarthritis. Both arthritis and frozen shoulders can present with stiff shoulders, but frozen shoulder usually follows a simple pattern of initially a lot of pain, felt predominantly anteriorly or laterally in the shoulder, bothersome particularly at night. It's a searing pain. It's often very emotional pain, such that the patient feels almost teary because they're exhausted from it. And then slowly the pain improves. But before the pain improves, the shoulder actually becomes stiff. So it goes through a painful phase, then a painful and stiff phase, and the pain slowly settles. And at this stage, the patient starts feeling better in themselves, even though the shoulder is still quite stiff. Eventually, the stiffness does resolve, although there's evidence that it never fully resolves, such that there's always a slight degree of minor stiffness. These are the three main conditions that affect the shoulder. The fourth one, of course, is another condition, is pain referred from the neck, as we discussed right at the beginning. Along with these traumatic presentations and elective presentations, there's variations of conditions as well. Recurrent dislocations are really an elective presentation of recurrent traumatic episodes, and that's also another cause of presentations to an orthopaedic surgeon. But as a part of that, you can also get subluxation episodes, which are a minor elective presentation, but really is an instability, or the labrum itself, which is a stabilising structure inside the shoulder joint around the edge of the glenoid, may have torn. And these labral tears can present with pain felt in the shoulder, particularly in certain positions, such as when throwing an item, such as a ball, or when sleeping or putting the arm in the abducted extreme rotated position. Labral tears used to be thought to be a very common cause of shoulder pain, but nowadays it's thought that it's probably less likely to be the cause of a shoulder pain in itself and more likely an incidental finding. It certainly can be a cause of shoulder pain, and particularly in patients that aren't getting better with other measures, but are less common than initially thought. As part of the labral tears, the long-headed biceps tendon attaches to the superior aspect of the labrum. Thus, the pull of the biceps tendon on the labrum can cause issues. This is the mechanism that's thought to be the cause of labral tears causing pain in itself, and one of the treatments can be releasing the biceps tendon off the labrum and reattaching it outside the shoulder. Apart from that, the actual biceps itself can also become inflamed and tendinopathic, and that itself can cause pain. This itself causes pain anteriorly in the shoulder along the long-headed biceps path, which is really in the bicipital groove, which is the space between the greater tuberosity and lesser tuberosity in the proximal humerus. This can easily be felt when the arm is palpated anteriorly and the forearm and the shoulder is externally and internally rotated. You'll feel the bicipital groove fairly easily. Biceps pain itself is often associated with rotator cuff spectrum, and as such, the actual biceps tendon may be treated at the time of rotator cuff surgery if surgery is warranted. So as a shoulder surgeon, I've been asked to make the diagnosis of what causes the shoulder pain, and I start off by saying, could it be coming from the neck? Could it be coming from the chest wall itself? And in the older person, it's always important to exclude cardiac cause for the left shoulder pain in particular. Once we're pretty sure it's shoulder, where in the shoulder is it causing pain? Is it more anteriorly, fitting more with the glenohumeral joint, or is it more laterally, fitting with the rotator cuff spectrum? The history helps a lot. Obviously, an older person is more likely to have arthritis than a younger person. The middle-age group, i.e. the 20 to 50-year-old, is more likely to have a frozen shoulder scenario. Obviously, if they present after a traumatic episode, we're thinking traumatic causes, such as fractures, dislocations, or the development of infection, which has been hidden by a traumatic cause, i.e. the person with infection may recall some minor trauma which has triggered off their pain. If they present in an elective presentation with insidious onset, we're thinking more of those three main diagnoses. However, these chronic causes or these elective presentations can present after minor trauma, and so we always need to keep them in mind as well. Past medical history always has to be taken into account as well, i.e. family history of dislocations or previous history of other joints being dislocated. Also, medications they're on might be worthwhile, and if they're a smoker. Also, work factors need to be taken into account if they do overhead work. When taking a history for an exam purposes, it's always important to know what previous treatment they've had as well. It's always important to know whether they've already received physiotherapy or received medication, whether they've tried a steroid injection into the shoulder, and also whether they've had surgery. When we come to examination, we look at the look, feel, move technique. We look from the front, the side, and the back. We look at the neck posture. I like to exclude the neck as a cause of shoulder pain from the start. And I usually start with flexion, extension, lateral rotation of the neck, and a combined manoeuvre of all three, extension, lateral flexion, and external rotation of the neck. It can cause the neuroforamen to close up. And this is known as Sperling's test or neuroforaminal compression. And it's a good way of excluding cervical spine entrapment as a cause of shoulder pain. If the patient experiences shoulder pain or paresthesia in the hand when they do that manoeuvre, we've got to think the cervical spine is the cause. When we look at the shoulder itself, we look from the front and the side and the back. We're looking at the shape of the clavicle, the shape of the sternoclavicular and acromioclavicular joints, any swelling in these areas, the actual shape of the deltoid, From the back, we can look at the supraspinatus fossa and the infraspinatus fossa, looking for wasting. And from the side, we can look at the posture of the arm and if there's any obvious associated scars. We then move to feel. It's very easy to feel around the shoulder or palpate the region. You can start at the sternoclavicular area and palpate along the clavicle to the acromioclavicular joint, which is a little bump on the lateral end of the clavicle. And it's the area where you'd put your handle of your rucksack on to help stop the rucksack falling off your shoulder. Going slightly lateral to that, you'll feel the edge of the acromion, and then even more lateral, the subacromial space. The humeral head seems to sit anterior in this area, so if you feel the actual anterior-posterior dimensions of the acromion, and then you'll find the humeral head is actually sitting in the anterior 50% of this area underneath the acromion. And you can feel down the lateral aspect of the shoulder in the subacromial area called the subacromial bursa. And if you palpate with one hand along the anterior aspect of the proximal humerus while you internally and externally rotate the shoulder, you'll feel the bicipital groove and the tendon. Medial to that, and just below the AC joint, is the coracoid. And going posteriorly, you'll feel the supraspinatus fossa, feeling for muscle bulk, and infraspinatus fossa. We'll then move to motion, or moving the shoulder. We go for the active motion first, and if there's any reduced range of motion actively, we then assess passive motion. We look at forward flexion, which is in the frontal plane, extension, which is going backwards, lateral abduction, usually with the hand externally rotated, and then we can do internal and external rotation with the arm by the side, which is a great way of assessing if there's stiffness in the glenohumeral joint, because if there is stiffness in the shoulder itself, there won't be, or there'll be limited external rotation, particularly assessed with the arm by the side. The reason is that the actual scapula can actually compensate for most or a lot of the shoulder motion and can fool the young examiner. However, because the scapula is stuck to the posterior chest wall, external rotation of the shoulder is not possible because the scapula has got nowhere to move to. Certainly forward flexion is helped by the scapula rotating in the coronal plane, and internal rotation of the shoulder is helped by the scapula curling around the lateral side of the chest wall. If there is limited active motion, we then assess passive motion. And I like to assess this by holding the scapula with my opposite hand. So if I'm examining a right shoulder, I'll put my left hand on the inferior border of the scapula and then help the forearm up in a forward flexion and abduction, assessing whether there is reduced range of motion, both passively. If the passive motion is reduced and if the scapula moves early, we're thinking a stiff glenohumeral joint. This will be seen both on forward flexion and abduction, and again reinforced by external rotation with the arm by the side. If there is a stiff glenohumeral joint, both passively and actively, then I'm thinking a condition which causes stiffness in the joint, which is either osteoarthritis or frozen shoulder. And the easiest way to assess between the two is by either feeling some bony crepitus or identifying on X-ray that there is arthritis. If the passive motion is very good, but the active motion is limited, then I'm thinking either the rotator cuff is completely torn, or very, very large tear, or there's a neurological issue, such as a C5 nerve root arising from the cervical spine, causing weakness of motion, particularly external rotation or abduction. If, however, the active range of motion and passive range of motion are very good, but there's a painful arc in the 70 to 120 degree range of motion, I believe that the most likely cause of this will be the rotator cuff spectrum, and depending on the patient's age and also depending on whether they've got weakness of motion, would help me to differentiate between bursitis, tendinopathy, and rotator cuff tear. If the pain, however, occurs at end range of motion, particularly if cross-arm adduction, such as doing the scarf test, this would make me think AC joint pathology. If, however, the pain is predominantly anteriorly and directly over the biceps tendon, I'm thinking more bicipital pain, or bicipital tendinopathy. Thus, by combination of a good history excluding other causes of shoulder pain, as well as a simple examination looking at both inspection, palpation, and motion actively and passively, we can get a pretty good idea of what the underlying condition is. Once we've finished the basic look, feel, move, we go to special tests. And they may start off with, if we're looking at rotator cuff spectrum, testing muscle power. And I like to test the external rotation of the arm, with the arm abducted by the side, as a way of assessing infraspinatus muscle strength. I assessed internal rotation, i.e. with the elbow forward flexed and the palm pushing onto the belly, as a belly press test, and this is a way of assessing the subscapularis. Whilst assessing supraspinatus is with the arm internally rotated, in the plane of the scapula, which is slightly forward flexed and slightly abducted, and at about 70 degrees of abduction and pushing up against the ulnar border of the forearm. And this is a way of assessing supraspinalis power. All the special tests which we need to assess are shoulder instability. If there's been a history of shoulder instability or of dislocation, or if there's a story of pain felt anteriorly in the shoulder or a sensation of the shoulder subluxing, or if when they experience pain when throwing, then a way to assess shoulder instability is by assessing the stability tests. Now, I would say the most important part of this is actually assessing the general patient's laxity as well. Make sure they can't hyperextend their fingers or their thumbs or their elbows, hyperextend their knees, or be able to touch their palms to the ground easily with their flat of their palms. These are ligament laxity tests, and if they have some instability issues, they usually have some degree of ligament laxity. If these are normal, and the shoulder can also be assessed by assessing sulcus sign, and this is where the patient is sitting on the side of the bed, the forearms resting on the lap, and gentle downward traction can put pressure on the shoulder to see if a sulcus or a little gap appears between the acromion and the proximal humerus. It is normal to have a small degree of motion, but if it is excessive, then this is a positive sign. We can test apprehension, which is the most important test. This is where the patient is lying flat or could be done standing. The arm is placed in abduction, external rotation, and forward pressure is placed on the proximal humerus while the arm is externally rotated. And often the patient will feel some apprehension or guarding of their shoulder or be concerned that the shoulder could dislocate or it feels painful. If while doing the same test by placing posterior pressure on the proximal humerus while pressing anteriorly, this is known as a positive relocation test. Finally, we can test for posterior instability by pushing the shoulder backwards with the arm adducted and flexed across the chest. So in other words, the elbow is flexed at 90 degrees, the upper arm is placed across in front of the chest, and the whole forearm is pushed backwards, trying to sublux the proximal humerus posteriorly. So the most common cause of shoulder pain I would see is the rotator cuff spectrum. That's the bursitis or tendinopathy if they're an older patient, or rotator cuff tears. As stated before, they present predominantly with pain worse at night, often when doing overhead activities, and usually with the arm in the 70 to 120 degree range of motion. In these scenarios, the treatment really is such that you need to address the cause. If they're doing a lot of overhead work, you might need to back off on that. You need to treat the pain with analgesics, and you might want to try an anti-inflammatory medication if the patient's suitable to try it. Usually with the course of physiotherapy to retrain the rest of the muscles and tone up the musculature around it, the patient improves. And a bit of period of rest, and then with some rehabilitation following the physiotherapy, most patients improve and don't need anything further done. If the pain continues to bother them, then a trial of a corticosteroid injection can be performed. And this is often done under an ultrasound guidance so that the actual diagnosis can be confirmed. Following that, if following a period of time and further physiotherapy the patient continues to experience pain, that's when a second steroid injection can be tried, but usually we wouldn't try more than one or two of them. If this continues to bother the patient, then we would consider a referral to an orthopaedic surgeon. One of the first tests we would like would be an X-ray. The X-ray will look at the degree of arthritis in the AC joint and whether this could be catching on the rotator cuff, the shape of the acromion and whether it's hooked or whether it's got an underlying spur, as well as to exclude any underlying arthritis in the proximal glenohumeral joint. Often at the time of the ultrasound for the steroid injection, the radiologist identifies a rotator cuff tear. Now, some of these are actually quite small and very minuscule and don't need anything further done. But if there's a larger tear, this may be something that could be addressed if the patient doesn't settle on their own. I would state that most rotator cuff tears don't cause long-term problems. And the vast majority of people can live with a rotator cuff tear, and actually by rehabilitating with physiotherapy and building up the muscles around it, they actually don't even know they've got a problem. There is one school of thought that the rotator cuff tears can become bigger and cause issues later in life, but often these don't. And if they do become more painful and continue to bother the patient, that's when the rotator cuff tear would normally be addressed anyway. So usually we'd try these simple measures first. But if the patient's not settling either with a rotator cuff tear or without, then they would be referred to an orthopaedic surgeon where the X-ray would be assessing whether there's a subacromial spur, whether there's AC joint arthritis, and also whether there's they would also want to exclude any underlying arthritis in the proximal glenohumeral joint. Assuming there's either impingement from underlying spur or AC joint arthritis, or there's a rotator cuff tear, surgery might be considered. And in that scenario, what we would do, either open or arthroscopically, would assess the rotator cuff repair the tendon by roughening the bone off the greater tuberosity and tying it down using sutures or with or without anchors into the proximal shoulder, and then taking away any underlying bone catching on the tendon, either from the AC joint or the lateral acromion. This is known as a shoulder arthroscopic or open decompression, bursectomy, cuff repair. And as part of it, we may, if there is arthritis of the AC joint or acromioclavicular joint, excise the lateral interclavicle, or if there's biceps tendinopathy or a labral tear that's causing issues, either repair the labrum or release the biceps from the labrum and reattach it outside the shoulder, known as a proximal biceps tenodesis. This is where the long-headed biceps is tied down to the proximal humerus so that it doesn't retract. There's a lot of evidence that actually the biceps can be released without issues, although some people might notice a deformity, and that can be concerning to the patient. But usually, the vast majority of patients don't have any issues from having the biceps released. But often we try and attach it outside the shoulder so that doesn't cause any shoulder cosmetic abnormality. The second most common cause of shoulder pain is frozen shoulder. This presents with pain and then pain and stiffness, and then the pain goes away and it remains stiff. Usually in the first few stages is probably the worst time to treat the patient because the shoulder for some reason is inflamed, and often if treatment is done too early, the condition can just flare up once again. However, if despite time and the patient's not settling, treatment is offered. The most important treatment initially is both diagnosis to exclude anything sinister, and then reassurance that it will get better with time. Sometimes analgesics and hydrotherapy are useful, but if all that fails, then the options of treatment involve either a steroid injection into the shoulder joint, with or without a fair bit of fluid being put in, called a hydrodilatation, to try and stretch the capsule up. Other options involve manipulating the shoulder joint or doing a telescopic release of the shoulder joint. All of these have benefits and merits. However, it has been proven a lot of these shoulders will improve with time, even without any further treatment. The reason for treatment is to try and help the patient get through the period and speed up the recovery. The final main diagnosis in the shoulder joints electively is arthritis. Now, I like to think of arthritis as being either primary osteoarthritis, secondary following trauma or infection or inflammation or a post-metabolic cause, such as gout or hemochromatosis, or an inflammatory arthritis, such as rheumatoid or psoriatic arthritis. Either way, the main treatment of arthritis is initially non-surgical, involving analgesics, or if it's an inflammatory condition, anti-inflammatory medication advised by the rheumatologist. But if the shoulder pain continues and there's a lot of deformity of the humerus and the glenohumeral joint, then a shoulder replacement may be warranted. And depending on whether the rotator cuff is intact or not, depends on the type of shoulder replacements that is performed. With an intact rotator cuff, we do a standard anatomical shoulder replacement where the ball is replaced with an artificial ball and the socket is replaced with an artificial socket. However, in the last 20 years, reverse shoulder replacements have become very common. And these type of shoulder replacements involve replacing the proximal glenohumeral joint with still an artificial socket and an artificial ball, but the ball is placed on the socket side and the socket is placed on the ball side. That's why it's called a reverse shoulder replacement. The advantage of this is it compensates for any torn or deficient tendons that may occur with age or with rotator cuff tears, such that if you don't have a intact rotator cuff, if you do an anatomical shoulder replacement and put the ball and socket in the anatomical position, there will be instability in the shoulder, just like we talked about before with a torn rotator cuff leading to secondary arthritis. This instability will lead to loosening of the plastic socket. Therefore, the reverse shoulder replacement helps hold the ball in the glenoid side and allows the deltoid to do the function for it. And these are probably the most common ones being done nowadays in South Australia and Australia on the shoulder registry. So I think that hopefully that outlines my approach to treating a painful shoulder, and hopefully it gives some direction to a medical student preparing for an exam, as such that they can actually divide the actual different conditions into certain little pockets of conditions such that they can help inform a diagnosis and then offer treatment options. Once again, I thank you very much for listening to my podcast, and we'll look forward to the next episode where we'll be interviewing another specialist in the area on a different condition. Thank you very much, and thank you for listening. The information provided to you today is designed to complement the information provided to you in your local region and should supplement your readings and teachings in that area. Please don't take it as the only way of treating this condition or assessing a condition, but really as one of various ways of assessing these conditions. Please also be aware that the information provided today is really just general medical advice and isn't designed to actually be a source of medical information regarding your particular condition. Remember to consult your specialist or medical practitioner if you have concerns about a condition raised in this podcast. Thanks once again for listening to our podcast, Aussie MedEd, or the Australian Medical Education Podcast. I really enjoy hosting this podcast. I hope you find it useful to hear a pragmatic approach to everyday conditions. If you have any questions or information you want to ask about us, or you'd like to put a suggestion for a topic, please don't hesitate to email us at gavin@med-ed.com.au. Once again, I hope you've enjoyed listening to it, and we'll look forward to hosting it next fortnight when we introduce a new topic. Thank you. Aussie MedEd is proudly sponsored by HealthShare, a digital health company that provides solutions for patients, GPs and specialists across Australia, and Tego, offering medical indemnity insurance for doctors. That's tego.com.au.